Good morning, everyone. I am so excited to get started today. If you don't mind putting in the chat box, if you can hear me and see my slides, that would be really helpful. Thank you. All right, we're going to get started in just a little bit. Just want to ask each of you to put in the chat box if you can see me, hear me, and can see my slides as well. Awesome. Great. Well, thanks so much for joining. Please make sure you have your chat box open. We are going to be having a jam-packed review today. And introduce yourself, say hello, where you're logging in from. I love connecting with each and every one of you. So we will get started in just a couple minutes. Thanks. All right, everyone. Well, good morning. It is 10 a.m. Eastern Standard Time. I am so glad you are here to join me today. Man, we have so many people on this webinar. I am so excited. If you haven't already, go ahead and open your chat box, say hello and where you're logging in from. I see Angelica from New York, Shanice from Toronto, Rebecca from Iowa, Funmi from Lincoln. Awesome. Santiago from Central Florida. We have Ellen from the Bay Area. Newport from Ohio. Wow, we have a wonderful community joining us. And I am so excited to get through yet another NBME Top Concepts review. Now, ladies and gentlemen, today is going to be a very, very special webinar. At the end, I'm going to be giving details on my new live course, which is coming out next month. So please stay tuned until the end of this webinar so that you can get the link as well as the informational material for that webinar. All right, so today we're going to be talking about renal top concepts from the NBMEs. If you're new, welcome. My name is Rahul. I'm currently a pediatric critical care fellow, and I have been absolutely passionate over the past 5-6 years helping students kick ass for the USMLE. If you have joined some of my webinars in the past, I welcome you back as well. And I do want to kind of take some time to just let everyone know, especially if you're new, what makes Hi Guru very unique. When I started this project about 6 years ago, I really wanted to focus on an evidence-based approach to USMLE preparation. And so today's lecture, as well as all of my lectures, they're focused on active recall. I also like to integrate across organ systems. And today we're going to be going through vasculitis as well as renal failure so that you can kind of conceptualize and understand both topics together. And then finally, I am very passionate about test-taking strategy. And throughout all of our multiple choice questions today, I will be giving you some nice little test-taking pearls so that you can apply them on test day. So when I prepare students from all around the world, as well as one-on-one, I kind of focus on this triad. And the first thing that I really like to go through is the application of content and test taking strategy. I have actually made a course that is just focused on test taking strategy for the USMLE. Because honestly, let's be honest, it's not just about the content, but it's how you apply the content, which really matters. I also like to focus on making sure that you are positive throughout your preparation. And finally, I use Notion to create dedicated study schedules so that students can really stay organized and productive throughout their studying period. I think most importantly, what has been absolutely awesome is that Hi Guru is a community. I have been absolutely blessed to teach at medical schools live, and COVID has especially taught us that medicine has no borders. And now we are a global community of lifelong learners. We have over 200 people joining this webinar live right now, both on Zoom and on YouTube. So this is going to be quite the review today. So just to give you a little bit of a background as to what inspired me to create this webinar, there was a Reddit post not too long ago that captured the most recurring concepts from the NBME practice exams. And as many of you know, we have gone through each of these systems. And today we are going to be covering our renal system. But if you are interested in looking at my prior lectures during your preparation, maybe even before your CBSE, you want to watch these lectures because they're only an hour long, check out my YouTube channel. Make sure you subscribe for the updates. And if you're really interested, you can sign up for my absolutely free Golion style top NBME concepts course, in which I take the same lectures and I break it down into a curriculum so that you are able to go through it in a systematic way. Before this webinar today, I did make a renal lecture available on this course so that maybe before or after this webinar, you'll be able to actually go through renal physiology, covering concepts like glomerular filtration rate, or taking a trip through the nephron. How does a proximal convoluted tubule work? How does the distal convoluted tubule work? And all of this is so integrative, and it focuses on the content that you will see on test day. So I think this is going to be probably the easiest question of the day. And that is, are you ready to get started? Go ahead and put yes into the chat box if you're ready to get started. Awesome. Brian's ready. Stephanie's ready. Leia's ready. Amisha's ready. I'm so excited. And guys, one disclaimer. Please, over the next hour and 15 minutes, just stay engaged. Open up the chat box so you can type in the answers. Make sure you're cutting out distractions. I promise you, this is worth your time. A lot of this content are from NBMEs, Qbanks, as well as my personal notes. So this is going to be jam-packed. All right, let's go into the outline for today. So what we're going to do first is we are going to be talking about the various casts you will see on your gross or microscopic pathology questions for the USMLE. We'll then turn our discussion to kidney stones, talk a little bit about nephrolithiasis and the different types of stones. Now, remember, the AMP or the struvite stones are going to have ammonia related to them. And so when we talk a little bit about ammonia, we will then integrate the urea cycle and get a little bit of USMLE biochemistry tie-in. The bulk of our lecture today is going to be focusing on the pathophysiology of nephrotic and nephritic diseases. We'll talk a little bit about normal glomerular physiology, and then transition our discussion into the three different types of renal failure: pre-renal, intrarenal, and post-renal failure. We'll also integrate a little bit of vasculitides in terms of going through Wagner's, going through your Goodpasture syndrome. This is going to be a nice integration where you can re-review the various types of vasculitis syndromes, which you will see on your exam. And then finally, we will be going through a high yield review on diuretics. And like I said, stay tuned until the end of this webinar, because I'm going to be releasing details of my brand new course, which is coming up next month live. I can't wait to share it with you. All right. Our first topic today is going to be casts. And remember, let's go ahead and open up that chat box so we can stay active and engaged. A 69-year-old male comes in with back pain, constipation, and fatigue. Patient's vital signs are stable. On exam, the patient has dry mucous membrane, so he's a little bit dehydrated. Hemoglobin is low. He has a normocytic anemia. You notice his BUN is high and creatinine is high. And the renal biopsy is notable for atrophic tubules and waxy casts, which stain intensely with eosin. What do you think is the most likely diagnosis? Go ahead and put your answer into the chat box. Just warming up today, guys. This is great. All right. We have a lot of nice answers. Make sure that you are going to be placing the answer to panelists as well as attendees so that you can all see the various answers. And the answer here is actually going to be D, a plasma cell neoplasm. Now, this is the presentation of multiple myeloma. And remember, multiple myeloma, you are going to be making a lot of immunoglobulins. And sometimes those immunoglobulins can actually deposit within the renal tubule. So before we go into the specifics of the cast, I do want to give you a little bit of a test taking strategy as to how I think about back pain for the USMLE. So these are just kind of general guidelines. They're mainly going to remain true, but you may see other causes of back pain. I did just want to put the high yield ones for you. So when you see an elderly patient, say that they're greater than 60 years old, what you will notice is that an elderly patient with back pain and they have symptoms of hypercalcemia, renal failure, you're going to be thinking about multiple myeloma. Now, say that they have a nodular prostate on digital rectal exam. Well, maybe that back pain is related to prostate cancer metastasis. What if you had this similar type of question, but it was a female or somebody who had a history of a mediastinal mass like Hodgkin's lymphoma? Well, then you're going to be thinking about more thoracic metastasis. So always remember that cancers can metastasize to the spine, and that can actually cause you to have back pain. Say that you have back pain related to an immigrant. Well, then you're going to be thinking about TB that went to the lumbosacral region. What about back pain that has bowel or bladder involvement within your test questions? Well, then you are going to be thinking of spinal cord issues. And this is where for step 2 CK questions, you're going to maybe start dexamethasone, urgent neurosurgical consultation, but you do need to know that you disrupt the enteric nervous system, you disrupt the various spinal nerves, such as the pudendal nerve, which is going to be important in bladder function. Finally, if you see back pain with point tenderness, especially in an elderly female who has signs and symptoms of osteoporosis or osteopenia, think about compression fracture. So the way that I like to teach this is I like to say, here is going to be a very common complaint that you get in your exam questions. And here are the various clues so that you can have a little bit of a comprehensive test-taking approach. All right, so what we're going to be doing is we're going to now be going through how I look at a urine analysis on the USMLE step 1. So for a urine analysis, you obviously are going to recognize that it's going to be in the labs portion of your vignette. They'll give you the chief complaint, they'll give you the past medical history, they will give you some vital signs, physical exam, and then finally they'll put labs, and within the labs, they'll maybe for a specific type of question, put in a urine analysis. Now on your UA, you are going to be looking at things such as specific gravity. And when I see that the specific gravity is going to be high, I'm going to be thinking of, man, you got really concentrated pee. And that concentrated pee can be seen in, for example, SIADH, in which you have so many different aquaporins, and that's bringing in free water, increasing your spec grav. What else could it be seen in? Dehydration questions as well. What about if you had a low specific gravity? Well, if you had a low specific gravity, you would be thinking about very dilute pee. Think about those patients who are going to have diabetes insipidus, in which they are going to have very, very low specific gravity and very dilute urine. The next thing you want to pay attention on, with for your urine analysis is going to be your leukocyte esterase. Now, leukocyte esterase is essentially going to tell you that, man, there are some WBCs in the pee, and they may indicate UTI, but they just may indicate that there are white blood cells in the urine. What's going to really indicate a gram-negative UTI is going to be the presence of nitrites. Remember that gram-negative bacteria, such as E. coli, are going to take nitrates and turn it into nitrites. And that's going to be very important for you to kind of recognize on your exam. Other major portions of the urine analysis are going to be things like heme, protein, glucose, as well as ketones. And what's going to be very important for us to recognize is that the presence of proteinuria is going to really key you in for nephrotic syndrome questions. The presence of ketones may key you in for not only your dehydration questions, but also remember diabetic ketoacidosis. And then the presence of glucose-urea is going to indicate that maybe your serum glucose is very high. Remember, just going back to renal physiology, if you have a glucose that is likely going to be greater than 200, you are going to then start spilling it into the urine because you have reached the transport maximum of the proximal convoluted tubules, SGLT2 transporters. So let's go through a little bit of an integrative vignette. A patient presents after being found crushed under a fallen set of bricks. Bruising is noted throughout the body. He is noted to have a urine analysis, which is heme positive. On urine microscopy, he has no RBCs noted. Creatinine is going to be elevated. What is the likely diagnosis? Go ahead and put that into the chat box. What do you think is the most likely diagnosis here? And many people are putting myoglobinuria or rhabdomyolysis, and you're absolutely correct. Remember that your urine dipstick can't really tell the difference between myoglobin and heme. And so when you're thinking about rhabdomyolysis, that is classically going to be presenting as a heme positive urine analysis, but subsequently on microscopy, you don't see any RBCs. And watch for that crush injury in which you get that muscle damage. Maybe it's going to be an elderly person who is found down for a long period of time. Remember that when you have muscle damage, what lab value is going to go up? It's going to be your CPK, and that can be seen in your exam questions as well. So now let's go ahead and talk a little bit about casts, because casts can be reported with your urine analysis, and casts can be reported specifically on your urine microscopy. When you're thinking of casts are essentially proteins which take the form of a tubule. And so whenever on the USMLE I see casts, I say that, man, the pathology is going to be either in the tubules or in the glomerulus. It's either going to be in the nephron or within the glomerulus. So casts indicate that you have an upper urinary tract issue, and that's high yield for us to recognize. All right. So what we're going to be going through are some really important vignettes. A patient presents with chronic renal disease / dehydration. A transparent cast is noted. What do you think this cast is? Well, this is going to be your TAM horsefall mucoprotein or hyaline cast. Now, this protein is actually going to be secreted by the proximal convoluted tubule in response to stress. And so this can actually be somewhat of a physiologic cast, but you do want to think of it, especially when you're talking about dehydration. Here's our next one. A patient presents with costovertebral angle tenderness, fever, and a UA that is positive for nitrates. So anytime I see CVA tenderness and a UA positive for infection, I'm going to be thinking about pyelonephritis. And that's where you're going to be integrating your WBC cast. Very high yield for you to know. How about this next one? A patient who presents with the upper respiratory tract infection plus anasarca, which is generalized edema. They are found to have 3+ proteinuria. So what does that tell you? That's going to tell you that it's a nephrotic syndrome. And they are noted to have a cast. And what cast is this? Yes, you got it. Fatty cast. Specifically, that Maltese cross pattern is going to be seen in your nephrotic syndrome patients. All right, finally, a patient who presents with cardiogenic shock, he is noted to have intrinsic renal failure, and UA shows casts that are muddy brown. And I apologize, for some reason, this version ended up cutting out the bottom portion of the vignette, so I totally apologize. So when you're thinking about ischemia to the actual tubules, you're going to be thinking about acute tubular necrosis. And acute tubular necrosis essentially represents that your proximal convoluted tubule cells that are very, very metabolically active ended up sloughing off and going in the lumen of the proximal convoluted tubule. All right. So speaking of CAS as well as urinary tract pathologies, let's go ahead and talk a little bit about kidney stones. One of the key USMLE strategies that I want to give you, especially when we're talking about kidney stones, is to essentially recognize in test questions where exactly abdominal pain is. So when you're thinking about abdominal pain, that is going to be placed right after the vital signs in your vignette and in the physical exam. And so USMLE questions localize pertinent areas of abdominal pain on the physical exam. And if you can kind of understand what all is in that region, that can allow you to isolate the diagnosis a little bit better. And from a test taking standpoint, I like to say that that ends up being a pertinent positive that supports your diagnosis as you go in and paraphrase the vignette. So when you're talking about kidney stones, for example, the USMLE typically talks about flank pain, and that flank pain will then radiate to the groin. When you're thinking about that flank pain, you're also going to be integrating dysmorphic RBCs on the UA. And that essentially represents the shearing of the red blood cells as they're coming from the kidney into the bladder. There's that shearing that is going to occur, and thus you get these dysmorphic RBCs. So let's go ahead and go through this question. A 40-year-old male comes in with right flank pain and nausea, which radiates to the groin. Sounds like a kidney stone to me. He is tachycardic and has mild tenderness to percussion on the right side. His testicular ultrasound is going to be negative. And I put this in the question to kind of give you an idea of a pertinent negative, which essentially is going to be something that you want to rule out. For example, if you have pain in the groin area, you may be thinking about testicular ultrasound, but this test question says that the testicular torsion, so this tells you that the testicular ultrasound is negative. The UA shows dysmorphic RBCs. Which of the following recommendations would most likely prevent this pathology, which is a kidney stone? Go ahead and put this into the chat. Limit fluid intake, high protein diet, increase calcium in the diet, high sodium diet, or use of loop diuretics. And the answer is actually going to be increased calcium in the diet. Remember that a moderate intake of calcium within the diet actually prevents kidney stones. You want to have increased fluid intake. You want to decrease protein in your diet. And especially, you don't want to do loop diuretics if you are going to be prone to kidney stones, because remember, loop diuretics, you lose calcium. So you are hypercalciuric. Thiazides would be a little bit more protective because thiazides cause you to become, watch my words, hypocalciuric. So let's go into a little bit of risk factors for kidney stones. Now, risk factors are starting to really come up on USMLE questions. And so let's integrate some of the key risk factors. Remember that if you are hypercalciuric, i.e. you're going to be peeing out a lot of calcium, you're going to be looking at things in your vignette such as hyperparathyroidism. Maybe they have an MEN syndrome. And remember, in MEN1 syndrome especially, you're going to have that parathyroid adenoma. Furosemide, we talked a little bit about how loop diuretics make you lose calcium. And in terms of dietary modifications, remember that if you have a high sodium intake and a high protein intake, you're going to actually be prone to kidney stones. If you have low calcium in the diet, you are going to be prone to kidney stones. And that's why our answer was increased dietary calcium. And it seems a little bit counterintuitive because majority of stones are actually going to be calcium-based, but the USMLE loves for you to know that a moderate amount of calcium intake in your diet actually prevents stones. You want to obviously recognize that dehydration predisposes you to stones. So these are these lifestyle modifications, and they can kind of pose this into a test question, just like how I did in the last slide. Other stones, which are going to be really important for us to integrate, are going to be things like uric acid stones. Now, remember, uric acid stones, you're going to be thinking about patients who have a high uric acid burden. So patients, obviously, with gout, maybe they have, for example, Lesch-Nyhan syndrome, or they have some sort of disease in which they have high amount of cellular turnover. CML, in which these patients have the Philadelphia chromosome that's rapidly progressing the cell cycle, polycythemia vera, etc. Struvite stones, which we will talk about, are going to be very large stones that are going to be associated with your urease positive organisms, Klebsiella and Proteus being your high yield ones. All right, so let's go into a little bit about nephrolithiasis. A large kidney stone in the distal ureter may cause what kidney ultrasound finding? This is an interesting type of question. Go ahead and put this in the chat if you know exactly what ultrasound finding would be seen in a lower kidney stone. Awesome. People are saying hydronephrosis, and you're absolutely correct. And this is something to definitely recognize. Remember that if you are going to have your ureter here, and here is your kidney, and this is where your bladder is, and say that you are going to have a stone that is going to be right here, that's going to cause a lot of back pressure and make your renal pelvis very dilated. And on ultrasound, we call that hydronephrosis. So in USMLE questions for nephrolithiasis, what may microscopy show? Well, we talked a little bit about the free dysmorphic RBCs. Now, what's the mechanism here? Well, very high yield for us to know that it is the disruption of the ureteral epithelium. Remember that there is this transitional balloon cell epithelium that is going to actually line the ureter. And so as there is that stone, you get disruption of that epithelium. So I had to integrate a little bit of anatomy for you in this review. And so I did want to ask you, the ureteral blood supply, where does it come from? Well, it kind of depends on where you're talking about. The proximal ureter gets the blood supply from the renal artery, which branches right off of the aorta, whereas the distal ureter gets blood supply from the superior vesicular artery. Remember, vesicular means bladder, and that is going to be a branch of the internal iliac. And so this type of anatomy integration is going to be really important, because say that you get a transplant question, a renal transplant question, they may ask you about this vascular anatomy. So I did want to just put a picture here for you. Renal artery gives rise to the proximal ureter, whereas the distal ureter, you're going to be thinking about the, superior vesicular artery. Okay, excellent. Let's go ahead and go through yet another NBME question. Again, very active and engaging session today. A middle-aged female presents with flank pain and hematuria. Sounds like another kidney stone to me. She has a history of UTIs. She has a blood pressure, which is elevated, and her prior urine cultures have grown Klebsiella and Proteus. CT is notable for calyceal dilation. Which of the following describes the pathogenesis of this patient's urinary tract infection? A small stone in the distal ureter. B, a stone composed of magnesium, ammonia, and calcium. C, hydrolysis of urea, precipitating alkaline urinary pH. Or D, low urine specific gravity. What do you think is the answer here? Okay, some people are saying B, some people are saying C. Go ahead, if you haven't participated yet, go ahead and type it in the chat. Awesome, I'm seeing a lot of great answers, and the answer is C. Remember that the stone that is going to be associated with urease positive organisms is ammonia, magnesium, and phos. And when you're talking about urease positive organisms, remember urease positive organisms are going to break down urea into NH3. And going back to renal physiology, Remember, NH3 acts as a buffer in the tubular lumen, and NH3 will give you an alkaline urinary pH. And so speaking of urea, we do have to do a little bit of a biochemistry integration, talking a little bit about the urea cycle. But before I move on, are you guys learning a lot? Go ahead and type in yes or no into the chat box. Excellent. We have a lot of people saying yes. I appreciate all of you sticking and paying attention. So I like to teach biochemistry in a very big picture and then focus down into the nitty-gritty details. I first just like to say, hey, why does our body just need this process? And that is to take ammonia and convert it into urea. That's the whole point of the urea cycle. And where do we get ammonia from? Well, we get ammonia from protein breakdown products. So where in the body does this process occur? Now, this is sometimes confusing to students. And so let me put it on the side for you. The urea cycle occurs in the hepatocytes, but then we excrete urea in the kidney. The process of the urea cycle occurs in the hepatocytes, but we excrete urea in the kidney. And so that's why I want to kind of integrate this key USMLE question. If they give you a patient with liver failure, and now they have this flapping tremor, i.e. signs of hyperammonemia, you can understand or integrate that the liver is going to be messed up, so you're not able to have good urea cycle, and thus ammonia is going to rise. So what is the rate limiting enzyme of the urea cycle? And that is going to be CPS1. Now, CPS1 is going to be a very important mitochondrial enzyme, and it's going to be one of the first enzymes in the urea cycle. Now, you want to contrast CPS1 from CPS2, and where did you hear CPS2 in your biochemistry study? And that is actually going to be in de novo pyrimidine synthesis. So I want to kind of tell you that when I teach, I like to give you some compare and contrast, some test-taking strategies, some integration, so that you are equipped for testing. And so then finally, the small details, what activates the urea cycle? Well, protein, N-acetylglutamate, which glutamate is going to be an amino acid. So protein stimulates the urea cycle. And so this is the whole urea cycle, but I'm going to give you the 4 facts that I think are important for your USMLE exam. We talked about CPS1. You do need to know that along with the heme synthesis pathway, as well as gluconeogenesis, heme synthesis, urea cycle, and gluconeogenesis have both mitochondrial and cytosol integration. There's an interface of the reactions in both areas. The other thing that I like for you to know is that fumarate actually then goes into the TCA cycle. So that's how urea cycle is linked to the TCA cycle, is right there. And then one of the key amino acid derivatives to urea, and that is part of the urea cycle, is actually arginine. And then finally is going to be this clinical vignette. A child with hyperammonemia, vomiting, high orotic acid, and low urea levels. Ooh, this is going to be the presentation of OTC deficiency. You don't have ornithine transcarbamylase, so you're going to have high amount of orotic acid. You're going to have low amount of urea because the cycle is not churning the way it should. And you're going to treat with what? A low protein diet. Why? Because you want to decrease the ammonia burden, i.e. decrease the protein metabolism burden, because this child doesn't have OTC, part of the urea cycle. All right, let's go ahead and talk now about the AMP stones. We are now done with the urea cycle. Let's go ahead and talk a little bit about the AMP stones. A patient presents with stones that are obstructing the renal pelvis. Proteus mirabilis is isolated on the urine culture. What is the mechanism behind these calculi? So going into the pathophysiology, protease is going to be urease positive. It obviously is going to hydrolyze urea to ammonia, which is going to give a high pH, and that's going to then precipitate your AMP stones. So just as a microbiology tie-in, go ahead and type in the chat. What are some other urease positive organisms? Go ahead and type that into the chat. Awesome. I'm seeing H. pylori. And if you haven't answered yet, I'd encourage you to continue to answer. People are saying Klebsiella. Very good. Excellent. I like to think of the mnemonic punch. Proteus, ureaplasma urolyticum, nocardia. Remember, nocardia is going to be partially acid fast. That's always going to be a test question. And don't confuse it with TB, partially acid fast. Cryptococcus, which causes a high pressure meningitis, especially in the HIV population. And then H. pylori, like many of you said. Staph saprophyticus and Klebsiella are also going to be urease positive. All right, so we talked about our AMP stones. Let's talk a little bit about our uric acid stones. What radiologic characteristic is notable with these stones? Well, these stones, just like cystine stones, are radiolucent. They don't show up well on X-ray. And so uric acid stones are radiolucent, along with cystine stones are radiolucent. Whoa. Uric acid and cystine stones are going to best be treated by alkalinizing the urine. Now, alkalinization of the urine serves to be the management step for uric acid and cystine stones, but what other key USMLE vignette? TCA overdose and aspirin overdose. Ladies and gentlemen, this is a one-stop shop. You're getting questions and content at the same time. Remember, another important fact is that your calcium phosphate stones and the AMP stones, which we just talked about, those stones form in an alkaline urine, whereas the cystine and the uric acid stones form in an acidic urine. And let's tie that back in. That's why alkalinization of the urine for uric acid and cystine stones are going to be the next best step in management. So what are some USMLE questions for uric acid stones? Well, I always have this mental model in my mind, and I say that, man, if there is going to be a high uric acid burden or there's a high cellular burden, I'm going to be more predisposed to uric acid stones. So let's go through this one. A patient who has recurrent gout presents with dehydration and a kidney stone. Remember, he has recurrent gout. A urine analysis shows the urine pH being low. Let's go ahead and integrate that to a fact here. What would urine microscopy show? Well, remember, your uric acid stones are going to have that rhomboid-shaped crystals. And that's exactly what it looks like. Let's go on and talk a little bit about calcium oxalate stones. A patient with Crohn's disease presents with flank pain and hematuria. Sounds like a kidney stone. A diagnosis of nephrolithiasis is made. Dang it, you gave me the diagnosis. What is the mechanism behind the likely stone? Well, this one is an interesting one. And the key to kind of hone in on or integrate is this disease of Crohn's disease, in which you have malabsorption. Now, what malabsorption causes is a bunch of free lipids within the intestinal lumen. And those free lipids actually are then going to bind up calcium. And so now oxalate is going to be free. And when oxalate is free, it can then go into the kidney and precipitate stones. Malabsorption conditions, you end up getting a high propensity for calcium oxalate stones. All right, ladies and gentlemen, let's go ahead and do a quick rapid review. A patient with Crohn's disease or ethylene glycol or hypercalciuria You're thinking about your calcium oxalate stones. Remember that you want to alkalinize the urine, and you're going to also be thinking about what? You're going to be thinking about a non-anion gap metabolic, or excuse me, an anion gap metabolic acidosis that is going to occur with your with the ethylene glycol poisoning. Patient with leukemia or gout, what are you going to be thinking of here? Well, you're going to be thinking about your uric acid stone. You want to be thinking about alkalinizing the urine. Patient with Proteus, your struvite stones. These like to form in a high pH environment. Patient with a COLA mutation in the proximal convoluted tubule, that's going to be your cysteine stones. Okay. And so just to make this a little bit more intuitive, and I do want to kind of let you know that when you're talking about calcium oxalate stones, that's different than your calcium phosphate stones. And remember, you're going to alkalinize the urine for not only this one, the uric acid stones, as well as the cysteine stones, but they don't necessarily test that too much in detail. All right, so the bulk of our discussion today is going to be talking about nephritic and nephrotic disease. And I'm going to try to do this in the next 15 minutes. It's going to be jam-packed, so buckle in. First, I'm going to give you a big overview as to what you need to know, big picture for nephritic and nephrotic for the USMLE. Number one, you're going to be talking about nephrotic diseases and how nephrotic diseases are going to present typically with edema, and they love to test you on the fact that it's due to low oncotic pressure. You also in test questions want to look for triggers such as URI, and then you have a nephrotic syndrome like minimal change disease. And remember, because you are peeing out so many proteins, these patients are going to be hyperlipidemic, both in the blood as well as in the urine, integrate our fatty casts. In nephritic syndromes, I want you to think about inflammation. And so a vast majority of patients in your vignettes are going to present with hypertension. They're also going to have oliguria because of the inflammation. And I think that this is really high yield for you to know, that patients with nephritic syndromes can have proteinuria, but it is not in the nephrotic range. Our first discussion will be regarding nephrotic syndromes. A child presents with anasarca. The patient has recurrent infections as well as recurrent varicoceles. Labs are notable for hyperlipidemia. UA shows fatty casts. I'm going to be going through an integrative approach on different pathophysiologic mechanisms. So first, we're going to tackle what is the mechanism behind the anasarca, and look at the colors in the vignette and the questions that I'm asking. The anasarca is going to be due to a loss of oncotic pressure. What about why the patient has hyperlipidemia? Well, this is going to be a reactive increase in lipoprotein synthesis. And so as you're losing protein, the liver says, whoa, I don't have any protein within the blood. Let me go ahead and throw out more lipoproteins. What's the mechanism behind recurrent infections? Well, a loss of immunoglobulins. And in nephrotic syndrome, you're losing protein. Guess what is the protein? Immunoglobulin. And then finally, why do these patients have sudden onset varicoceles that are recurrent, or DVTs, or renal/mesenteric vein thrombosis? Go ahead and put that in the chat. Why do you think these patients have these recurrent hypercoagulable conditions? Awesome. I'm seeing that. And the correct answer is loss of antithrombin 3. So when you revisit the slide, look at the various different colors. And now what I did was kind of integrate the pathophysiologic mechanisms. All right, so nephrotic syndrome, let's go through it. A child presents with scrotal edema and eye puffiness. He had a history of URI 1 week ago, and that's the trigger. A diagnosis of minimal change disease is made. What is the most likely light microscopy in minimal change disease? And that is going to be normal glomeruli. The pathophysiology of minimal change disease is actually really important for you to understand. And that is that cytokines, say from the urinary tract infection, or excuse me, from the upper respiratory tract infection, from the URI, or from Hodgkin's disease, causes you to have a loss of charge to the basement membrane. And that causes you to have that diffuse podocyte effacement on electron microscopy. What is going to be the likely management? Well, corticosteroids. And remember, minimal change disease is going to be very steroid responsive. So let's go through a little bit of an integration here. Minimal change disease, the light microscopy shows normal glomeruli and maybe some lipid in the proximal convoluted tubule. On the electron microscopy, you are going to see this podocyte effacement. Because there's no immune complex deposition, your immunofluorescence is going to be negative. And remember that there's an association with Hodgkin's disease as well as a steroid responsiveness. All right. A 50-year-old obese African-American patient with a past medical history of HIV and sickle cell disease states that he has been noticing increased fatigue and swelling in his legs. He is non-compliant with this treatment, and social history demonstrates long-standing heroin abuse. On labs, he has 3+ proteinuria and fatty casts, so he has nephrotic syndrome. What is the likely diagnosis? And I kind of wanted to integrate some high-yield risk factors in this vignette, and the answer here is focal segmental glomerulosclerosis. What may electron microscopy show in FSGS? Well, the same thing as minimal change disease, podocyte effacement. So how do you tell the difference? FSGS is poorly responsive to steroids, whereas minimal change disease is actually going to be very responsive to steroids. So FSGS, focal segmental glomerulosclerosis, integrate the risk factors from this slide, as well as the fact that it's poorly steroid responsive. Let's go through the pathophysiology now. Light microscopy is going to show fibrous deposition and hyalinosis, as you can see here. Electron microscopy is going to show podocyte effacement. Immunofluorescence is going to be negative as there's no immune complex deposition, and we talked about the steroid responsiveness. Next question here. A 40-year-old female with a history of lupus presents with proteinuria. She is noted to have ANA positive and anti-double-stranded DNA antibody positive. Kidney biopsy is determined to be the next step. The sample is notable for irregular spikes protruding from the glomerular basement membrane. What is the most likely diagnosis? A, minimal change disease. B, diffuse proliferative glomerulonephritis. C, membranous glomerulonephropathy. Or D, membranoproliferative glomerulonephritis. What do you all think? Awesome. We have a host of answers, and majority of them are saying C, and you're absolutely correct. Remember that membranous glomerulonephropathy is going to be the nephrotic syndrome presentation of lupus. And how I like to integrate that is I like to say that you are a member of the lupus community. So membranous and lupus nephrotic syndrome, that's kind of how it helps me integrate, or that mnemonic helps me integrate that fact. So on the light microscopy, you are going to see thick glomerular basement membranes due to immune complex deposition. And on the electron microscopy, you are going to see that classic spike and dome appearance in which you have subepithelial deposits right on the actual podocyte membrane. And then the actual basement membrane reacts and it causes you to have a spike and dome, spike and dome. So here's a spike, dome, spike and dome. And I remember the M right here to kind of help me remember of the spike and dome appearance. But remember, it's going to be a reaction of the basement membrane, and that kind of relates it to the light microscopy finding as well. Because there's immune complex deposition, you're going to have a granular immunofluorescence. And another important fact for you to recognize is that membranous glomerulonephropathy can be associated with antibodies to phospholipase A2. The next nephrotic syndrome, which we're going to be going through, is going to be membranoproliferative glomerulonephritis. Remember that there are type 1 and there's a type 2. Type 1 is usually going to be associated with Hep B and Hep C infections. You're going to be thinking of type 1 as having not epithelial, but endothelial deposits. And it affects the classical complement pathway, and that's why you have low C1. Contrast that with type 2, in which you have actual basement membrane deposits. So subendothelial, that's different than the basement membrane. In type 2, you have dense deposit disease on the basement membrane. The mechanism here is the C3 nephritic factor, which stabilizes the C3 convertase. You keep churning through the complement pathway, and you get low C3 levels, which are related to your alternative pathway. Both type 1 and type 2 membranoproliferative glomerulonephritis can have that classic tram tracking appearance on your electron or light microscopy, and that is going to be splitting of the basement membrane due to the proliferation of the mesangium. Speaking of complement, let's go through complement deficiencies for the USMLE. What do you guys think? A teenager with recurrent nephritic infections, go ahead and put that in the chat. What do you think is going to be the likely missing factor here? Awesome. I'm seeing a lot of C5 to C9, and you're absolutely correct. The membrane attack complex. The key points here, and this is higher level stuff, is that remember that eculizumab, which is going to be a C5 complement inhibitor, actually has a side effect of causing recurrent nephritic infections. Swollen lips, swollen tongue, and wheezing, and say it's familial or say that it's recurrent. You're going to be thinking of hereditary angioedema. And that is a C1 esterase inhibitor deficiency. So remember, C1 esterase inhibitor, when you have it, it normally decreases bradykinin. But if you have a deficiency of C1 esterase inhibitor, you are going to have high kallikrein activity and thus high bradykinin that leads you to have the airway swelling and the mucosal swelling seen in hereditary angioedema. A patient with sudden onset mesenteric vein thrombosis plus back pain. And here you're going to be thinking of a decay accelerating factor deficiency or a CD59, CD55 deficiency, and that's going to be paroxysmal nocturnal hemoglobinuria. Many presentations are going to be related to this hypercoagulable state in which you end up getting clotting in very weird vessels. And so watch out for that presentation of PNH. All right, so summary of membranous diseases. We talked about subendothelial for type 1 MPGN. We talked about the basement membrane deposits for type 2 MPGN. And then for membranous, we talked about the subepithelial. And remember that that causes a reaction to the basement membrane, causing your spike and dome appearance. All right, ladies and gentlemen, let's go ahead and close out nephrotic syndrome by talking a little bit about the most common cause of ESRD in the United States, which is diabetic glomerulonephropathy. So I'm going to explain the pathophysiology of diabetic nephropathy. Here you have the afferent arteriole. Here you have the glomerulus. Here you have the efferent arteriole. Diabetes actually is going to have preferential non-enzymatic glycosylation of the efferent arteriole. When you have efferent arteriole vasoconstriction due to the non-enzymatic glycosylation, you end up causing a little bit of back pressure. And physiologically, you increase your glomerular pressure. Now, that can cause a transient increase in your GFR as you constricted the efferent arteriole. However, what's important for us to recognize is this integration with chapter 1 of pathoma, cell injury, death, and adaptations. This efferent vasoconstriction ends up being a cellular stress to the glomerulus, causing you to start proliferating your mesangium. And when you proliferate your mesangium, what do you end up forming? Those classic Kimmelston-Wilstein nodules that are going to be seen in diabetic nephropathy. Moving on, we are going to be talking about nephritic syndromes. Let's go ahead and start with our question. A child presents with hematuria. The patient is noted to have hypertension, oliguria, and periorbital edema. Yet another integrative mechanisms question. What is the mechanism behind hypertension? Well, remember, nephritic syndromes are all about inflammation and salt retention, secondary to activation of RAS. Why do you get periorbital edema? Well, a couple of mechanisms. One is because of the salt retention. Maybe you also have that non-nephrotic range proteinuria that's contributing to it. But remember, histologically, the tissue behind the eye is in a very loose organization. So that histology tie-in is actually really important, because then you recognize that because there's a loose type of organization of the tissue behind the eye, that ends up being a potential space for fluid. And in nephritic syndromes, the urine analysis typically shows dysmorphic RBCs as well as RBC casts. Here's a nice pathophysiologic diagram looking at nephritic syndrome and this whole concept or theme that I'm building of inflammation related to nephritic syndrome. Remember that majority of nephritic syndromes are going to start with immune complex deposition. And just to relate that to USMLE immunology, that's a type 3 hypersensitivity reaction. You end up activating complement because of the antigen antibody deposition. And one of the factors of complement is going to be C5a. And what does C5a do? Well, C5a is actually going to recruit neutrophils. And that leads to the hypercellular glomeruli. Remember that Pathoma nicely presents that C5a, IL-8, LTB4, and bacterial products recruit neutrophils. And this is where we take renal, get into a little bit of chapters 1 through 3, and then we move on. A 6-year-old male presents with blood in his urine after having a URI and a sore throat. He is noted to be hypertensive. The urine analysis confirms hematuria plus non-nephrotic range proteinuria. So he has a nephritic syndrome. What do you think is the most likely diagnosis? Go ahead and put that in the chat. And many people are saying PSGN. And what I want to kind of turn your attention to is the fact that this question doesn't necessarily show you a timeline. And I want to bring this up because timeline, when it comes to sore throat and hematuria, is actually pretty important, along with complement levels. If in the test question they put 2 to 3 days after a URI and a sore throat, the patient ends up having hematuria, then you're going to be thinking of IgA nephropathy. Whereas if they say 2 to 4 weeks after the URI and sore throat, they have hematuria, then you're going to be talking about PSGN. And how do you tell them apart as well? Not only just from the time period, but the fact that PSGN usually has low complement levels. So IgA nephropathy, let's integrate the key points. On the light microscopy, you're going to see mesangial proliferation. On electron microscopy, you will see immune complex deposition. Immunofluorescence is going to be granular, secondary to the IgA deposition. And typically, you're going to have a normal serum complement. And the way that I remember it is the fact that, remember, IgM and IgG are the ones that typically fix complement, not IgA. Another high-yield test question, which is always asked, is that, remember, IgA structurally is a dimer, and they love for you to know that. Let's go ahead and integrate IgA nephropathy with this vignette. You have a 6-year-old child who has bloody stools and colicky abdominal pain. He is noted to be tachycardic and hypertensive. There are raised purple, red skin lesions along the buttocks and lower extremities. What is the likely diagnosis? This is an interesting one. And that is going to be henoch purpura. The colicky abdominal pain, which refers to this predisposition to intussusception, and the palpable purpura on the buttocks are key. Remember that when you're talking about henoch purpura, it's going to be an IgA vasculitis, and there are multiple USMLE presentations. Remember, as this is a multi-system disease, you're going to see things like arthritis. You're going to see palpable purpura on the lower extremities, the dermatological finding, the renal disease, which is associated with IgA nephropathy, as well as intussusception, because you end up getting a hyperplasia of the Peyer's patches, which ends up being a lead point for the telescoping of the bowel. A child is noted to have red urine. He has a history of atopic dermatitis. He was treated for a skin infection a few weeks ago. Guys, remember this. This is a trigger. He is noted to have hypertension, and his BUN to creatinine ratio notably shows intrinsic renal damage. What is the likely mechanism behind this patient's condition? Go ahead and type that into the chat. A, CD8 lymphocytes. B, histamine release. C, autoimmune IgG antibodies. Or D, IgG immune complexes. And many people are saying D, and you're absolutely correct. I do want to turn your attention to the fact that he has atopic dermatitis. He has a predilection to get skin and soft tissue infections related to impetigo. He may have gotten the nephritogenic strain, and this is going to be a very classic presentation of post-streptococcal glomerulonephritis. Ladies and gentlemen, let's go ahead and integrate PSGN. So on light microscopy, you are going to see a lot of inflammation. Electron microscopy, you're going to see these subepithelial humps. As the deposits start subendothelially and then they move up, that can kind of help you remember that it is that subepithelial humps. Remember, in nephrotic syndrome, membranous glomerulonephropathy gave you subepithelial deposits, whereas PSGN in nephritic syndrome gives you subepithelial deposits. Integrate, 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 compare, and contrast. Immunofluorescence is going to be notable for a lumpy, bumpy granular appearance. We talked about the time period. We talked about a little bit on the fact that because you get the nephritogenic strain, remember that the nephritogenic strain is defined by the M protein, which has the immunologic mechanism of molecular mimicry. And this is a type 3 hypersensitivity reaction in which you eat up your complement. I do want to go into an integrative diagram on lupus. When you're thinking about lupus-associated renal disease, remember the nephrotic syndrome presentation was the membranous, I'm a member of the lupus community. And the nephritic presentation is going to be diffuse proliferative glomerulonephritis, in which you have the capillary wire loops seen on histology. DPGN nephritic presentation, but remember that these patients can progress to, oh snap, rapidly progressive crescenteric glomerulonephritis. Rapidly progressive crescenteric glomerulonephritis on your USMLE is going to be an acute renal failure that progresses over the course of a few short weeks. And there are multiple triggers: PSGN in older patients, lupus, IgA nephropathy could do this, as well as henoch purpura. So essentially, RPGN, or rapidly progressive crescenteric glomerulonephritis, can be thought of as a spectrum of disease. What's important for us to know is histologically, these crescents are made up of fibrin and macrophages. So some conditions can actually predispose you to developing rapidly progressive glomerulonephritis. One of the conditions that can be associated with RPGN is Goodpasture's, in which you have hemoptysis and hematuria, It's a type 2 hypersensitivity reaction to the anti-GBM, the same basement membrane that's in your lungs causing the hemoptysis, as well as in your kidney causing hematuria. You also want to integrate microscopic polyangiitis. This type of vasculitis can cause hemoptysis and hematuria. It is P-ANCA positive. Remember, that stands for myeloperoxidase. And it can be precipitated by drugs or infection. Moving on, we talk about granulomatosis with polyangiitis. That is C-ANCA positive. That causes not only your hemoptysis and hematuria, but you also get a chronic sinusitis associated with Wegener's disease. Now remember that when you're talking about C-ANCA, that is antiproteinase 3. That's different than the P-ANCA. But both MPA and GPA are going to be called pauci-immune causes of hemoptysis and hematuria, as well as RPGN. There's not necessarily immune complex deposition, but there is ANCA positivity. But wait, let's integrate just a little bit more. And that is when we talk a little bit about microscopic polyangiitis, both microscopic polyangiitis and Churg-Strauss, also known as eosinophilic granulomatosis with polyangiitis, both of them are going to be P-ANCA. So how do you tell the difference? Well, Churg-Strauss actually has asthma, eosinophilia, and granulomas. So that can help differentiate the Churg-Strauss disease from microscopic polyangiitis. All right, guys, let's go ahead and move on. We have 2 more topics to talk about, and then we're done. I'm going to be talking next about renal failure. A 50-year-old male is admitted for heart failure. He has started on furosemide. He is noted to have a baseline BUN concentration of 12 and creatinine of 1.2, but then on day 5 of his hospitalization, the BUN rose to 40 and creatinine rose to 2.1. What is the likely mechanism? A, increased upregulation of aquaporins. B, ureteral compression leading to hydronephrosis. C, tubular necrosis. Or D, decreased efferent perfusion. And in this scenario, when you're thinking about the ratio, BUN to creatinine, it's going to be 20-1. And we're going to likely be thinking of a pre-renal azotemia due to what? You got it, due to the furosemide. Remember that furosemide causes a contraction alkalosis. When you have a volume contracted state, you actually end up firing RAS, and downstream, you end up firing ADH. And thus you get upregulation of aquaporins that then bring in the BUN. So let's go through the pathophysiology of pre-renal azotemia. Some form of low effective perfusion to the kidney can predispose you to pre-renal azotemia. So either you are having low perfusion to the kidney because of congestive heart failure, because of renal artery stenosis, hypovolemia. You may have GI losses that are causing you to be dehydrated, or skin causes. Either way, low effective perfusion to the kidney is going to activate RAS. And when you have RAS activation, you're going to then subsequently get a low urine sodium because aldosterone brings in that sodium, but also because of the volume change, you're going to increase ADH. And remember, ADH goes to the distal collecting duct and causes you to have aquaporins being upregulated. And these aquaporins being upregulated are going to bring in water as well as BUN, leading to your BUN to creatinine ratio of greater than 20-1. Let's go ahead and wrap up renal failure. So a patient who has renal artery stenosis, hypovolemia, or CHF, or on diuretics, you're going to be thinking about the pre-renal azotemia. The key points are the BUN to creatinine ratio. And remember, you don't want to give NSAIDs when people have pre-renal azotemia because the afferent arteriole is primarily controlled by your prostaglandins. And so if you give NSAIDs, you inhibit cyclooxygenase, and thus you decrease prostaglandins, and thus you can worsen the renal failure. How about this one? A patient has acute tubular necrosis due to sepsis or is on an aminoglycoside, which is nephrotoxic, or it gets contrast, or has HUS or TTP, you're going to be thinking of intrinsic kidney failure. And watch for your muddy brown cast when you're thinking about acute tubular necrosis. Remember that your kidney is intrinsically damaged, so your fractional excretion of sodium, you're going to be peeing out a lot of sodium. They have phases in which you have oliguria, and then as the tubules are going to re-epithelialize, you're going to have this dumping of urine. And look for in your exam questions the BUN to creatinine ratio of about 10 to 15 to 1. A patient with a kidney stone, BPH, neoplasia, or posterior urethral valve. What kind of renal damage is this going to be, guys? Go ahead and put it in the chat. Good, excellent. You're going to be talking about your post-renal azotemia. And post-renal azotemia is going to cause you to have hydronephrosis. And I think that this is a really important physiologic mechanism in which, because you have so much backup, your Bowman space hydrostatic pressure, is actually going to be increased. And if that post-renal stress is going to be there long enough, that can end up causing you to have intrinsic renal failure. So my test taking strategy here, guys, is to actually focus on the BUN to creatinine ratio in your labs. All right, ladies and gentlemen, the last section here is going to be on diuretics. Are you guys learning a lot? Go ahead and put yes or no in the chat box. Awesome. Angelica, Nana, Leah, Mutu, Brian, thanks so much for participating, everyone. I do have a special announcement, and the way that I'm going to be teaching diuretics is the way that I'm going to be teaching many pharmacological agents for my upcoming course next month, which is the USMLE Step 1 Pharmacology Rapid Review course. It's going to be next month live, May 15th to 16th. I do want to be fully transparent. This is one of the paid webinars, and I will be focusing a lot on drug mechanisms and integration with pathophysiology and physiology so that you can actually integrate these various drugs. One way that I'm going to be teaching the pharmacology is using a reverse pyramidal approach. Essentially, for each agent, I'm going to be giving you the big picture. Then I'm going to be going into the mechanism of action and correlating the mechanism of action to the pathology or pathophysiology. I'm going to subsequently be giving you the specific names, and I'm going to be going through the side effects of the specific agents. So for example, when I'm teaching diuretics, big picture, they make you pee. The mechanism of action, well, it depends on the diuretics, but essentially they affect various portions of the nephron to inhibit transporters. The specific names, the ones that we are going to be going through today, are acetazolamide, furosemide, and hydrochlorothiazide. And then side effects are going to be very drug specific, but all of them are going to cause you to have volume contraction and can predispose you to pre-renal azotemia. Why? Because all of them make you pee, and you can then be intravascularly depleted. All right, couple more questions, and then we're done for the day. 65-year-old male presents with a skin rash and fever. He is noted to have a history of gout and congestive heart failure controlled on furosemide and NSAIDs. Watch for that trigger. The urine analysis is notable for pyuria with no nitrites. But urine microscopy shows eosinophils. What is the likely mechanism? A, immune complex deposition. B, autoantibody inflammation. C, IgE-mediated hypersensitivity reaction. Or D, CD8-positive interstitial damage. All right, people are putting great answers within the chat box, and the answer is going to be C. This is your acute interstitial nephritis. Key things are going to be the drug trigger, as well as the eosinophilia within the urine. So a USMLE test taking tip, especially when it comes to pharmacological agents or a prodrome of a upper respiratory tract infection, you're going to be wanting to isolate triggers in test questions. So in this case, the trigger were NSAIDs and diuretics, and those can both lead to acute interstitial nephritis. So the three major diuretics I'm going to be focusing on are acetazolamide, hydrochlorothiazide, and loop diuretics, and then we're done. Acetazolamide, the mechanism of action is that it is a carbonic anhydrase inhibitor, and it is going to actually inhibit the proximal convoluted tubule. Very important for you to know. Acetazolamide is going to be used in many conditions, but in particular, the USMLE wants you to know that it is used in acute closed angle glaucoma to reduce intraocular pressure. It decreases the aqueous humor because at the level of your ciliary epithelium in your eye, there is that carbonic anhydrase enzyme. So if you give acetazolamide, you inhibit carbonic anhydrase in the eye and thus decrease aqueous humor production, and subsequently, you are going to decrease intraocular pressure. Because acetazolamide causes you to pee out bicarb, you can end up getting a non-anion gap metabolic acidosis associated with acetazolamide. Next one we're going to be talking about is going to be furosemide. Furosemide is going to be a diuretic that inhibits the sodium potassium 2-chloride channel at the ascending loop of Henle. USMLE vignettes are going to be very, very integrative when it comes to furosemide, but the highest yield one, in my opinion, is somebody who has congestive heart failure, and they give you that cardiac pathophysiology tie-in, in which you give furosemide to decrease preload and myocardial oxygen demand, as well as to relieve the symptoms of shortness of breath. Remember that furosemide is going to cause you to have a contraction alkalosis. The alkalosis is going to be due to the fact that you're upregulating RAS and peeing out H+. And furosemide is also going to be ototoxic. And what are other ototoxic agents the USMLE likes for you to know? Aminoglycosides, as well as the chemotherapeutic cisplatin. Finally, we're going to be talking about hydrochlorothiazide. The mechanism of action here is going to be a inhibition of the sodium chloride symporter, where at the distal convoluted tubule. The USMLE vignettes here are the fact that hydrochlorothiazide in the pediatric ICU, we also use it very commonly to augment our diuresis. We give Lasix, which is furosemide, as well as hydrochlorothiazide. You also want to use hydrochlorothiazide for patients who may have hypertension and osteoporosis. And why is that? Well, it's because the side effect of hydrochlorothiazide we use to our advantage, and that makes it exceedingly high yield. Hydrochlorothiazide causes you to become hyperglycemic, lipidemic, uricemic, but most importantly, calcemic. And that's why that hypercalcemia helps with patients who are osteoporotic as well as have hypertension. And remember that hydrochlorothiazide can be one of the treatments for nephrogenic diabetes insipidus. All right, just closing down this session today, let's just do a quick compare and contrast with loops and thiazides. Loop diuretics, furosemide, torsemide, bumetanide. Loops lose calcium, so they cause you to become hypocalcemic. They can cause you to have interstitial nephritis, as we saw in the vignette related to that sulfa moiety, and it can worsen gout, similar to the thiazides. Thiazide diuretics are going to be hydrochlorothiazide, chlorthalidone, and metolazone. They cause you to become hypercalcemic and hypocalciuric, a very stark contrast compared to the loop diuretics. And because they cause you to become hyperuricemic, they can also worsen gout. But both of these cause that contraction alkalosis. And this is going to be our final concept of the day. And that is going to be the pathophysiology of contraction alkalosis. Again, my goal is to take pharmacology and integrate it with pathophysiology so that you can have a more applied approach that not only helps you for your exam, but sets you up for success in your clerkships as well as step 2 CK. So both diuretics cause low effective perfusion to the kidney. You end up getting a high renin-angiotensin aldosterone system activation secondary to the volume contracted state. And then subsequently, your aldosterone is going to start becoming increased. Low renal perfusion activates RAS. Once you have aldosterone increased, you're going to pee out potassium. You're going to pee out H+. And remember, if you lose H+, you end up getting alkalosis. So contraction, and then you're going to be thinking of alkalosis. And remember, normal physiology is right here. Aldosterone helps you bring in sodium and makes you pee out potassium and hydrogen ions. So in summary today, I wanted to kind of go through our key test-taking pearls. One of the things that I do is when I'm going through a test question and I see a pharmacological agent, I actively recall the mechanism of action immediately. I say furosemide. Okay, so sodium, potassium, 2-chloride transporter causes contraction alkalosis. Bam, right in the moment. Subsequently, I also want you to integrate the test-taking strategy of identifying triggers. We saw that in minimal change disease with the URI, then leading to nephrotic syndrome, or even with the drug trigger causing the acute interstitial nephritis. And then finally, I would encourage you to learn pharmacology in a reverse pyramid approach. Same with biochemistry, big picture, and then go down to the details. Remember, for pharmacology especially, integrate the pathophysiology. Ladies and gentlemen, thank you so much for your attention today. If you stick around for just 2 more minutes, I want to give you more information about my upcoming pharmacology masterclass, which I mentioned was going to be held May 15th through the 16th. The reason why I made this webinar was because, number one, pharmacology comprises of about 20% or more of the USMLE. And guys, these are easy points. And remember, in October 2020, the step 1, the USMLE entity, ended up coming out with a statement saying that there's going to be an increased focus, especially on step 1, on understanding of the drug mechanisms. And so this live course is going to be helping you integrate pathology and pharmacology together. And right now in the chat box, I'm going to go ahead and place the links for you to sign up and an informational flyer if you want to think about it, and then get the early bird pricing. As many of you know, I have other resources. One of the most popular resources is this test-taking masterclass, which kind of teaches you some important test-taking strategies, gives you that one-on-one private tutoring experience. And then if you need a dedicated study schedule, please do not hesitate to check out my dedicated study plan, as well as it comes with a little bit of a course on how to review UWorld, how do I get productive, et cetera, et cetera. That short course really helps students as they embark in their dedicated study. All right, ladies and gentlemen. Well, before you leave, I do want you to note that you can connect with me on Instagram, YouTube, Reddit, as well as via email. My email is rahul@higuru.com. So please feel free to email me with any questions. And lastly, before you leave today, go ahead and type into the chat, even if you're on YouTube as well, one thing that you learned that you can use for your next round of studying. Go ahead and put that in the chat. And afterwards, I will be doing a live Q&A. Thank you so much for your attention today.